Dear colleagues, welcome to this podcast. I am Dr. Bengu Nisa AKAY from Ankara University, Department of Dermatology. Cases in this podcast were asked on the IDS Dermatoscopy page, and the correct answer was either never received or very few people were able to find the answers. Let's start with the first cases. We have 3 pink nodular lesions. All were located on the foot and all were solitary. There is one melanoma here, and can you decide which one is melanoma? At first glance, all 3 look like pyogenic granulomas. The first one has a white line that intersects the lesion, while the other 2 have a colored white line. The first lesion may also be capricious sarcoma because of the rainbow pattern or polychromatic color change and because of the purplish red color. Some of our colleagues can perform destructive treatments such as laser therapy, cryotherapy, electrocauterization for pyogenic granulomas, often taking without biopsy. If cryotherapy or laser was performed to the third lesion, a disaster would have been caused because the third lesion is an acral melanoma with a Breslow thickness of 4 mm. Therefore, taking a small biopsy before treatment can be life-saving. The first one was Kaposi sarcoma, the second one was pyogenic granuloma, and the third one was nodular melanoma. Now let's look at these 2 lesions with similar dermatoscopic findings. One is located on the nose and the other one on the forehead. Almost all members considered BCC, basal cell carcinoma, in their diagnosis. At first glance, they really both look like clear-cut basal cell carcinoma with focused serpentine and branched vessels, and especially in the second image, we can see some gray dots and clots reflecting basaloid tumoral islands. But when I said that these 2 lesions are not basal cell carcinomas, then these differential diagnoses came from the members: dermal nevus, sebaceous carcinoma, poorly differentiated squamous cell carcinoma, and trichoblastoma. The absence of ulceration and the presence of many bright white-yellow clots may also suggest 2 benign skin tumors that are clinically and dermatoscopically similar to basal cell carcinoma. The first one is trichoblastoma and the second one is trichoepithelioma. Our third case is a 72-year-old female. The lesion was located on the forehead and appeared 2 years ago and showed slow growth. The members mainly considered epidermal cyst, basal cell carcinoma, pilomatricoma, xanthogranuloma in their differentials. There were also few members thinking about tumors of sebaceous origin. At first glance, due to serpentine and branched vessels, it looks like a basal cell carcinoma. However, the background color is yellow to orange, which is suggestive of a sebaceous origin. So the differential diagnosis should include sebaceoma, sebaceous adenoma, or sebaceous carcinoma. Since the histological spectrum extends from that seen in sebaceous adenoma to lesions that may be difficult to distinguish from sebaceous carcinoma, the lesion was totally excised and histopathology was consistent with sebaceoma. When histopathology is consistent with tumors of sebaceous origin, Muir-Torre syndrome should be considered, and the patients should be investigated for an underlying tumor, especially colorectal, genitourinary, and visceral adenocarcinomas. Again, an atypical lesion suggesting the spectrum of keratinizing tumors like squamous cell carcinoma or keratoacanthoma, and the diagnosis can only be made pathologically. None of the members could get the right diagnosis here. Histopathology was compatible with sebaceous adenoma. Case 5 is a 45-year-old female. The lesion occurred 6 months ago and it was located on the upper lip. Dermatoscopically, we see unfocused blue-gray structureless area blue-gray dots, white structureless area, keratin mass, and unfocused serpentine vessels. The differential diagnosis of the members were mainly basal squamous carcinoma, squamous cell carcinoma, and basal cell carcinoma. However, no one can get the right diagnosis. It was microcystic adnexal carcinoma. Microcystic adnexal carcinoma is an uncommon malignant adnexal neoplasm and is classified as a low-grade sweet gland cancer. It's characterized by keratin-filled cysts, nests, and course of basaloid cells. Therefore, this tumor may show dermatoscopic similarities to basal cell carcinoma, basal squamous carcinoma, or squamous cell carcinoma. It's a locally aggressive tumor, deeply infiltrative, and can invade bone, muscle, blood vessels, cartilage, and nerves, despite which the metastatic potential is very rare. This is another challenging case. No one could give the correct answer in this case. Dermatoscopically, the lesion includes features of both basal cell carcinoma and squamous cell carcinoma. In the right part, inside the blue circle, you can see coiled vessels, and there are some linear vessels shown by blue arrow, and there's a keratinizing area shown by yellow arrow, and we can see also fiber sign reflecting the microulceration, and there are serpentine vessels marked by red arrows. This was histopathologically again another microcystic adnexal carcinoma. Case 7 is a 7-year-old girl. She was brought by her parents for a nodular lesion located on her abdominal region. The lesion developed 2 years ago and started to grow in the last 2 months. On physical examination, it was very firm on palpation, and the dimension of the lesion was 15 by 10 millimeter. This pink dome-shaped nodular lesion dermatoscopically was presented by a pink and white structureless areas, focused and unfocused serpentine and branched vessels. The members thought about this could be a Spitzoid, and some others consider leiomyoma and pilomatricoma. Histopathology of this nodular mass was consistent with fibrocollagenous type of dermatofibroma. Here we can see the correlation of the vessels in the histopathological sections. Dilated vessels are beautifully presented here. Nodular dermatofibromas before puberty is really very rare, so this was very surprising for all of us. Here we see 2 similar lesions. Both lesions were located on the lower leg, both were firm on palpation, and dermatoscopically both look like dermatofibroma. The one on the right side is a dermatofibroma, but the one on the left is not. So what can be the first one? For the first one, although central white structureless area and brown circles are suggestive of dermatofibroma, there is something unusual for dermatofibroma here. When pressure is applied on the surface with the dermatoscope glass, a yellowish color is observed. This is a ruptured epidermal cyst. Yellowish structureless area may be a clue for epidermal cyst in terms of reflecting the contents of the cyst. If we compare again both cases, yellow structureless area with the pleasure of the dermatoscope, epidermal cyst, and we don't see yellow structureless area in the second image, and this was fibrocollagenous type of dermatofibroma. This slide is a repetition. Again, we see similar lesions. The one on the right side is a dermatofibroma. When the glass of the dermatoscope is pressed, the lesion turns white. We don't see any yellow color in the second case. But if we have a look at the first case, with the pressure of the dermatoscope, we see prominent yellow structureless area, which is also histopathologically consistent with epidermal cyst. Another very interesting lesion. The patient is a 29-year-old male. His barber noticed the lesion. It was an asymptomatic one. Dermatoscopically, we see blue-gray and white structureless areas, centered vessels, and white circles. The The differential diagnosis of the members were mainly nodular basal cell carcinoma and trichoblastoma, and also melanoma, cellular blue nevus, irritated seborrheic keratosis, and poroma. But the histopathology was none of them. It was a malignant tumor. It was porocarcinoma, a very rare tumor. Another very interesting case, we couldn't get the right answer in this case also. The patient is a 60-year-old male referred to our outpatient department for the evaluation of an ulcerated enlarging lesion which had been present for 3 months. The patient had a liver transplantation surgery 6 years ago and had been under tacrolimus with mycophenolate mofetil combination after transplantation. And his physical examination revealed a tender 1.2 by 1.9 centimeter ulcerated crusted nodular lesion with indurated borders on the right parietal region. Dermatoscopy shows a central keratin mass with blood spots, peripheral serpentine and branched vessels, white lines, pink and white structureless areas. The preliminary diagnosis of the members were mainly in the keratinizing tumor spectrum, BCC, basosquamous carcinoma, well-differentiated squamous cell carcinoma, and atypical fibrocarcinoma. But histopathologic examination was a real surprise to all of us because it was consistent with leishmaniasis. Histopathologic examination showed diffuse dermal lymphohistiocytic infiltration and numerous non-causating granuloma formations with peripheral dense lymphocytic infiltration along with epidermal ulceration. Higher magnification also showed numerous MS-zygote-laden histiocytes with lymphocytes and plasma cells beneath the epidermis. With these findings, the patient had been diagnosed with cutaneous leishmaniasis. Another very challenging case, the patient is a 45-year-old male. He had a family history of melanoma and this lesion occurred 1 year ago. He has severe sun-damaged skin and the lesion was enlarging slowly. On dermatoscopic examination, we see pink and white structureless areas, white lines, and multifocal erosions shown by blue circles. Most members consider superficial basal cell carcinoma in their preliminary diagnosis, and some others consider lichen planus-like keratosis, Bowen's disease, and actinic keratosis. They are all very plausible differential diagnosis, but histopathology was none of them. It was follicular infundibulum tumor, in other words, infundibuloma. In tumor of the follicular infundibulum, the tumor forms anastomosing narrow strands that run parallel to the epidermis, and these strands have peripheral palisading of basaloid cells. Anastomosing thin strands running parallel to the epidermis are generally not seen or only focally seen in basal cell carcinoma. Tumor cells of the tumor of the follicular infundibulum are generally pale pink or glycogenated rather than basaloid throughout. Another differential diagnosis with the follicular infundibulum tumor is fibroepithelioma of Pinkus, and they can be distinguished from each other on its hair germ differentiation of fibroepithelioma of Pinkus. This is another challenging case. The patient is a 36-year-old female presented with a lesion on her left side of the abdominal region that had been present during pregnancy and gradually growing for the last 2 years. On examination, there was a firm, heavily pigmented papillary lesion with a diameter of 13 by 9 mm. Dermatoscopic examination revealed circumferential radial lines, eccentric black structureless areas, gray to black dots and clots distributed all over the lesion, and bluish-gray structureless areas. With these dermatoscopic findings, most members consider Spitzoid versus Spitzoid melanoma in their differential diagnosis, and some others consider seborrheic keratosis and very rarely basal cell carcinoma. Histopathologic examination revealed a tumor extending downward from the epidermis to the dermis with thin anastomosing cords and islands of basaloid cells showing peripheral palisading with numerous melanophages, and it was consistent with Pinkus fibroepithelioma, which is a subtype of basal cell carcinoma, and we know that Pinkus fibroepithelioma is most commonly presented as non-pigmented lesions. Heavily pigmented Pinkus fibroepithelioma is extremely rare. If we have a look at the dermatoscopy one more time, we will see some radial lines converging to a common base as we used to see in basal cell carcinoma. So this is a very rare presentation of basal cell carcinoma mimicking melanoma and Spitzoid. Case 14 is a 6-year-old male who was brought by his family because of a nodular lesion on his arm that had grown in the last 2 months. Dermatoscopic examination revealed pink and white structureless areas, hemorrhage, brown clots, serpentine vessels, blue-gray structureless areas. With these dermatoscopic findings, the members considered this could be a wart, pyogenic granuloma, Spitzoid, or keratoacanthoma. Histopathologic examination of the total excision material showed an epidermal ulcerated polypoid tumoral lesion. The cells that formed the tumor were atypical melanocytes with hyperchromatic nucleus and coarse melanin granules. You can see the lymphovascular invasion and the red circle. Ki67 proliferation index was high in melanocytic cells that are stained red chromogen. With these findings, the histopathologic diagnosis was Spitzoid melanoma with a breast of thickness of 3.4 mm. Ulceration was positive, mitosis was 10 per millimeter square, lymphovascular invasion was positive, and sentinel lymph node biopsy showed subcapsular micrometastasis. Another very interesting case. The case is a 65-year-old male presented with a 1-month history of painful adjacent blue and red nodules on his left foot. He had undergone heart transplantation 2 months ago and he was immunosuppressed with methylprednisolone, mycophenolate mofetil, and tacrolimus. Physical examination revealed adjacent blue crusted and red ulcerated nodules on his medial aspect of the left foot. Dermatoscopic examination of the pink nodule showed polymorphic vessels, mainly serpentine, coiled, looped vessels, and some vessels have bulbous endings. There was also hemorrhage and clot vessels of different sizes. The other lesion showed blue structureless area with a central keratin mass, and there was hemorrhage on the surface. With these dermatoscopic findings, the members more commonly consider this could be a Kaposi sarcoma related with the immunosuppression, and some others consider melanoma, poroma or porocarcinoma due to the vessels with bulbous endings, squamous cell carcinoma, and pyogenic granuloma. Histopathologic examination of the pink nodular lesion gave the impression of deep fungal infection. The smaller nodule was also excised for tissue culture, and the first image of the histopathological sections showed prominent dermal capillary proliferations, which is correlated with the dermatoscopic polymorphic vessels. In the second image, shown by blue arrow, there is fungal hypha as basophilic globular structures in the multinucleated giant cells, and red circles are PAS-positive fungal hypha in the multinucleated giant cells. The tissue sample was inoculated on the sebarodextrose agar and potatodextrose agar, and white powdery colonies of Trichophyton rubrum were observed in the cultures. So deeper dermal dermatophytosis should be considered in the differential diagnosis of painful, rapid growing lesions with atypical clinical and dermatoscopic features in immunosuppressive conditions. Another interesting patient. The patient is a 78-year-old female. She admitted with a 6-month history of asymptomatic flat lesion on her right heel. Dermatoscopic features were highly suspicious for acral melanoma, and most of the members consider melanoma in their differentials. The suspicious dermatoscopic features for melanoma are chaotic arrangement of pink, white, and gray structureless areas and dotted vessels. At first glance, the tiny flat pigmented lesion on the inferior side of the larger lesion, shown by arrow, is suspicious for micrometastasis of melanoma. However, it's an acral nevus with parallel furrow pattern. You can see here. Histopathology of an incisional biopsy from the pigmented part showed that the main lesion was Bowen's disease, and Bowen's disease on acral sites may mimic acral melanoma as observed in the present case and should be kept in mind in the differential diagnosis of melanoma. My last case is a 69-year-old female who was found to have this 7 by 8 mm flat pigmented lesion on the right inner surface of the labium majus and pigmented group of tiny macules on the left side of the larger lesion. She wasn't aware of the lesion. She gave a history of unilateral vulvar itching and burning for the previous year. Dermatoscopic examination of the larger lesion showed chaos of colors and structures, eccentric radial lines, gray, black, white, and pink structureless areas, black clots, and polymorphic vessels, including dotted, serpentine, and linear vessels. The smaller tiny macules were composed of dermatoscopic brown-gray dots, except one. That one showed a structureless eccentric black area and eccentric distribution of dark brown dots. Both clinical and dermatoscopic differential diagnosis included melanoma with in-transit metastasis, pigmented pudgy disease, Bowen's disease, seborrheic keratosis, and basal cell carcinoma. Excisional biopsy was taken from the larger one, and histopathological examination was consistent with multifocal superficial basal cell carcinoma, and the tiny pigmented macule was consistent with mucosal melanosis. Histopathology showed a very intense melanin pigment in the basal layer keratinocytes and the vulvar epidermis, with the lesions consistent with mucosal melanosis. You can see this in the last histopathological image. I hope I was able to make a useful presentation. Thank you for your patience. Goodbye.